Welcome back to the deep dive. I was looking through the stack of research you sent over for this week, and one number just completely jumped out at me. 100 million.
Yeah, it is a staggering number, isn't it?
It really is. That is roughly the number of electrocardiograms, ECGs, performed in the U.S. alone every single year.
It's arguably the most ubiquitous medical test on the planet. I mean, you see it everywhere.
Right, it's in the ambulance, the ER, the GP's office. My smartwatch even claims to do one now.
Exactly. And because it's so common, we have this collective assumption that the ECG is, well, objective truth.
You hook up the wires, the machine prints that little pink grid with the squiggly lines, and that is a definitive picture of what the heart is doing. End of story.
It's a very comforting thought. We want to believe the line doesn't lie, because if the line lies...
Where does that leave us?
Right. Where does that leave the person trying to save your life?
Exactly. But digging into these sources, the systematic reviews on diagnostic accuracy, the guides on lead placement, the research on algorithms, that assumption starts to crumble pretty fast.
Oh, it falls apart completely.
It turns out that squiggly line is actually a minefield. We're talking about errors that range from where a nurse places a sticker on your chest to whether the computer inside the machine is actually, hallucinating a diagnosis.
It is definitely not as simple as pushing a button. The reality is that the ECG is a tool, but it's a tool that is incredibly sensitive to human error and technological bias, too.
And the consequences aren't small.
No, we are talking about everything from a false alarm that just scares the living daylights out of a patient to missing a lethal rhythm entirely because someone just trusted the default settings.
And that is exactly our mission for this deep dive. We're going to become ECG literate.
Love that phrase.
We're going to move past just staring at the squiggles and hoping for the best. We need to unpack the mechanics of regularity, find the ghosts in the machine, and look at the life or death difference between a wide, complex rhythm and a simple sticker mistake.
And we're going to do it without sounding like a dry cardiology textbook. The goal here is practical application for you, the listener.
Absolutely. Oh, and before we dive into the weeds, a quick mention that this deep dive is brought to you by Whole Life Healthcare.
They are big proponents of accurate diagnostics and keeping hearts healthy, so we're thrilled to have them along for the ride.
Always good to have partners who care about health literacy. So let's start at the absolute foundation. You have this strip of paper in front of you. Before we get into heart attacks or rare diseases, there is one fundamental question we have to answer first.
Right. Is the heart beating regularly?
It sounds almost too simple to mention.
It does, but it is the gateway to the entire diagnosis. If
Yeah.
you get the regularity wrong, you are likely going to get the rhythm wrong.
Because everything flows from that one binary choice, regular or irregular.
Exactly. And what I found fascinating in the research is that in our high-tech, AI-driven world, the absolute best way to figure this out is incredibly low-tech.
The sources keep referring to something called the paper trick.
I love the paper trick. It is the definition of old school cool. It is completely foolproof.
You don't need fancy digital calipers?
No computer analysis tool needed. You just need a scrap of paper and a pen.
Okay, so walk me through this. Say I'm an EMT or a med student or just a curious listener. I've got a rhythm strip in front of me. What am I physically doing?
Okay, so visualize the ECG strip. You see those big spikes, the tall peaks of the
The
heartbeat?
QRS complexes,
Yeah.
specifically the R waves, the very top of the spike.
Exactly. Now, you take a blank piece of scrap paper, just the straight edge of it, and you lay it over the ECG strip. You align the edge of your paper with the peaks of those R waves.
Okay, paper's down. I'm covering up the top of the grid.
Now, take your pen. You are going to draw 2 dots on the edge of your scrap paper. You mark at the top of one R wave and then the top of the very next R wave.
So essentially, I've just physically captured the distance, the interval between two beats.
You've got it. 2 dots, 1 interval. You have measured time on a piece of scrap paper.
Okay, I have my measurement. What's next?
Now, here is the magic. You slide that paper to the right along the ECG trace. You move it so your first dot aligns with the next heartbeat. Then you look at your second dot. Does it land perfectly on the tip of the subsequent beat?
Oh, I see. You're basically using the first 2 beats as a ruler for the rest of the strip.
Precisely. You slide it across, typically a 6-second strip. If those 2 marks continue to align perfectly with the tops of the R waves beat after beat throughout the whole strip...
Then the rhythm is regular.
Exactly.
And if they don't hit the marks, if the beat falls short or goes long...
Then it's irregular. And the beauty is, it is immediate visual confirmation. You
Yep.
aren't guessing. You aren't just eyeballing it. You measured it.
It's like a manual slide rule for the heart. I imagine in a chaotic ER where your eyes can play tricks on you, having that physical verification is huge.
It grounds you.
But why is this distinction, regular versus irregular, so critical right off the bat? Why does it matter if it's off by a millimeter?
Because your differential diagnosis, the list of things, it could be branches immediately right there. If you find that it is irregularly irregular, meaning there is absolutely no pattern to the chaos,
The beats are just all over the place.
right, then you're immediately thinking atrial fibrillation, AFib.
But if it's regular, you're in a completely different bucket of diagnoses.
It changes everything about how you treat the patient.
So rule number 1, don't guess. Measure the R to R intervals on a 6-second strip with the paper trick.
Yeah.
But speaking of guessing, that brings us to our next segment, which I found honestly a little disturbing. We need to talk about the computer interpretation.
Ah, yes, the automated diagnosis, the text at the top of the page.
You know the one? Every modern ECG machine prints that block of text at the very top. It says things like normal sinus rhythm or anterior infarct, and I feel like 90% of the time, even trained professionals just read that and nod.
We treat the computer like the expert in the room.
Which is a dangerous trap, right?
Very dangerous. In the industry, we call it automation bias. It looks authoritative. It's printed in crisp black and white font. It's calculated by a machine, so our brains assume it's objective.
But the data you brought says otherwise. One of the systematic reviews showed that 31.3%, almost a third of those automated reports, require modification by a physician.
That is a massive error rate for a medical device.
It really is. Imagine if your speedometer was wrong 30% of the time. You'd get a lot of speeding tickets.
And with ECGs, it's not just random errors either. The machine actually has a specific personality, if you will. It has anxiety.
The machine has anxiety. That sounds oddly human.
It does, doesn't it? It tends to overdiagnose. It wants to find things. It is programmed to be highly sensitive because the manufacturers obviously don't want it to miss a heart attack.
Okay, so it's overly cautious.
Right. So, for example, the algorithms frequently overcall inferior infarcts. Humans have to go in and delete that diagnosis in 32% of cases. And for anterior infarcts, it's deleted 44.6% of the time.
So the machine is screaming heart attack, and the doctor has to look at it and say, no, calm down, it's fine.
Exactly. It also loves to diagnose electronic ventricular pacemaker or prolonged QT interval, even when they just aren't there. It sees a shadow and thinks it's a monster.
But surely it's better to be safe than sorry. Better to overcall it than undercall it.
In theory, yes. But false alarms cause alarm fatigue, which we'll get to later. And more importantly, the machine does have blind spots. It underdiagnoses certain things.
Like what?
Specifically, the very thing we just talked about, atrial fibrillation.
Wait, so the machine struggles with the exact thing we can solve with a scrap of paper.
It's ironic, isn't it? In one study, the machine missed the diagnosis, these are false negatives, in 19% of atrial fibrillation cases.
19%. That is 1 in 5 patients where the machine says regular or sinus rhythm, but the patient is actually in AFib.
And if you miss AFib, that's not a small thing. AFib causes clots. If you miss it, you aren't putting the patient on blood thinners.
And that patient is essentially walking around with a ticking time bomb for a stroke.
That is the real-world consequence of trusting the text at the top of the page without verifying it.
Why is the computer so bad at this, though? I thought AI was supposed to be smarter than us by now.
Well, we have to clarify. Most hospital machines aren't running cutting-edge neural networks yet. These are often basic rule-based algorithms, and they heavily struggle with artifact.
Artifact meaning noise, like if the patient moves.
Exactly. If the patient shivers or shifts in the bed, the baseline of the ECG wobbles. The machine sees that wobble and immediately thinks fibrillation. Or it sees a bit of electrical interference from a nearby device and thinks pacing spike.
So it's hallucinating based on noise.
We have a phrase for this in medicine. Treating the monitor, not the patient. The computer is a second opinion, and frankly, it's often the opinion of a very nervous, over-caffeinated medical student. You have to be the attending physician who actually verifies it.
Okay, so we can't fully trust the machine's brain. But surely if we hook up the wires correctly, the raw data itself, the squiggly lines on the page, is accurate, right?
You would hope so, but that brings us to the concept of garbage in, garbage out.
We're talking about lead placement errors.
This is where human error physically alters the data before the machine even has a chance to process it. And the stats here are honestly staggering. Up to 50% of ECGs have leads V1 and V2 placed too high.
50%. That's a coin flip.
It is.
Okay, let's visualize this for everyone. V1 and V2 are the stickers that go in the middle of the chest, near the sternum.
Right. They're supposed to be specifically at the fourth intercostal space. That's the space between the fourth and fifth ribs. But finding that space takes a moment. You have to physically feel for the rib angle, count down.
And in a busy ER, or with a patient who might be obese, people often just guess.
Exactly. They put them at the second or third intercostal space to save time.
But does a couple of inches really matter that much?
It changes everything. If you place V1 and V2 too high, you are essentially looking down at the heart from above rather than straight on. This changes the angle of the electrical vector. It can create a pattern that mimics an anterior myocardial infarction.
A fake heart attack.
Or something called a Brugada sign, which is a rare genetic condition that can cause sudden death.
Let me get this straight. You could technically rush a patient to the cath lab for an invasive heart procedure or diagnose a terrifying genetic disease just because the sticker was 2 inches too high on the chest.
We call it a pseudo-infarction. It looks like a heart attack, it smells like a heart attack, but it's literally just a sticker problem.
That is wild. And looking at the notes you sent, that's not the only placement error. There's the horizontal mistake too.
Right, leads V4, V5, and V6. These go around the side of the chest under the left breast area. They are supposed to form a perfectly horizontal line. But think about the human body. The ribs curve upwards towards the armpit.
So people naturally just follow the ribs.
Exactly. We call it armpit drift. About 33% of the time, these leads are misaligned. Often V5 drifts right up into the armpit. This completely distorts the lateral view of the heart.
What does that look like on the readout?
It can mimic ischemia, lack oxygen where there is none, or even worse, it can hide ischemia where it actually exists.
So we have the machine panicking and we have humans putting stickers in the wrong place, creating fake heart attacks. But there is one error in the sources that seems even more dramatic. The mirror effect.
Limb lead reversal. This is an absolute classic.
This is when you swap the left arm and right arm cables, right?
Correct. You're hooking up the patient, maybe the cables are tangled, maybe you're rushing. You accidentally clip the left arm wire to the right arm and vice versa. It seems like a simple mix-up, but the ECG looks completely bizarre.
How do you spot it? Is there a tell?
There is a massive tell, but
Yeah.
you have to know to look for it. You look at lead eye. In a normal heart, lead eye should be mostly positive. The spikes go up. If you swap the arms, lead eye becomes completely inverted. P wave, QRS, T wave, everything goes down.
That's a complete flip.
And then you look at lead AVR. Now, AVR is usually the forgotten lead. It looks at the heart from the right shoulder. Since the heart's electricity naturally moves down to the left, AVR usually sees the signal going away from it. So AVR is normally negative.
But in a reversal.
In a reversal, AVR becomes positive.
So if I'm looking at a strip and I see an upside-down lead eye and a right-side-up AVR, I shouldn't assume the patient's heart has physically flipped over inside their chest.
Unless they have dextrocardia, where the heart is literally on the right side of the body, which is incredibly rare. It just means you cross the wires.
I feel like that is such a great aha moment for anyone looking at a strip. Don't panic. Check the wires.
Always check the patient before you panic. That's a good rule for medicine in general.
Speaking of panic, let's move to a scenario where panic might actually be justified. We are talking about the high-stakes world of tachycardia. The sources went deep on wide, complex tachycardia.
This is truly one of the scariest things to see on a monitor.
Set the scene for us.
You have a patient. Their heart is racing over 100 beats per minute, often much faster. You look at the ECG, and the QRS complex, that main spike, is wide. It's fat. It measures over 120 milliseconds.
So the electrical signal is taking a long time to get through the ventricles. It's sort of sludging through.
Correct. Now, you have a massive dilemma on your hands. Is this ventricular tachycardia VT, which originates in the bottom of the heart and is potentially lethal? Or is it supraventricular tachycardia SVT, which comes from the top of the heart but is just conducting badly?
SVT with aberrancy.
Exactly. Maybe they have a bundle branch block, so the signal is slow, but the rhythm itself is coming from the top. SVT with aberrancy is generally stable. VT is a precursor to cardiac arrest.
So if you guess wrong.
If you guess wrong, you might kill the patient.
That's terrifying. Why?
Because the treatment for SVT is often a drug called adenosine. It blocks the AV node. If you give that to a patient in VT, especially if they are unstable, you can actually precipitate cardiac arrest. You can crash their blood pressure completely.
So the golden rule is, if it's wide, assume it's VT until proven otherwise.
Always. Wide equals VT until you are 100% sure it's not.
But how do we become 100% sure, or at least sure enough to treat? The sources gave us some detective clues to tell the difference.
There are 3 big clues to look for. The first is AV dissociation. This is the hallmark of VT. It means the atria, the top of the heart, and the ventricles, the bottom, are beating to their own drums. They are completely divorced.
How do you see that on the strip? It sounds like chaos.
It is really hard to see. You have to look for P waves that are just marching through the QRS complexes with no relationship, but sometimes you get lucky and see capture beats or fusion beats.
What is a capture beat?
It's when, in the middle of this wide, bizarre rhythm, a normal, narrow beat sneaks through. It's like the normal conduction system briefly captured the heart for one single beat.
So a normal beat in a sea of chaos proves it's the bad rhythm.
Ironically, yes. Because if it was SVT with a block, every single beat would be blocked. The fact that a normal beat got through proves the system works, and the wide rhythm is actually coming from somewhere else, the ventricles.
That is counterintuitive, but it makes perfect sense.
Okay.
Clue number 2, the rabbit ears.
This is a purely visual one. You look at lead V1. If the QRS complex looks like 2 rabbit ears, you check which ear is taller.
Left or right?
If the left ear is taller, that is highly specific for VT.
Left is lethal.
That's a great mnemonic. In a standard right bundle branch block, which is the safer SVT option, the right ear is usually taller, so left ear taller equals VT.
And the third clue involves a map. The northwest axis.
Right. We talk about the electrical axis of the heart. Usually electricity flows from the top right down to the bottom left. If the axis is pointing northwest, meaning it's negative in lead I and negative in lead AVF, it's pointing up and to the right.
Into no man's land.
Exactly. The heart shouldn't conduct that way unless the signal is starting from the very bottom of the ventricle and shooting upwards. So northwest axis equals VT.
Now, those require a bit of analysis, but you mentioned earlier that AVR is the forgotten lid. One of our sources, the Verikai algorithm, says AVR is actually a superhero for this exact diagnosis.
It really is. The Verikai algorithm is fantastic because it's fast. In an emergency, you don't always have time to calculate access or hunt for hidden P waves. This is a life hack. You just look at lead AVR.
And what are we looking for?
As we said, usually AVR is negative. Everything goes down. If you see a dominant initial tall R wave in AVR, so it shoots straight up right at the beginning of the beat, it is almost certainly VT.
Just that one lead.
Just that one lead. If the electricity is rushing towards the right shoulder, towards AVR, it has to be coming from the ventricles.
That is incredibly actionable. Just look at AVR. If it's positive, you're in trouble.
It's an absolute game changer for quick decision making.
So let's zoom out a bit. We've covered the paper trick, the line computer, the armpit leads, and the lethal rabbit ears.
Yeah.
We've talked about a lot of potential errors.
Yes, and we have to remember, these errors don't happen in a vacuum. They happen in busy hospitals, with tired staff, often in the middle of the night.
One of the sources mentioned alarm fatigue. I think we've all experienced this, even just listening to a car alarm outside that won't stop.
It's a massive clinical problem. You have these machines that are oversensitive, as we discussed. They beep for everything. Low battery, poor lead contact, high rate, review rhythm.
And if the leads are loose or placed wrong, they beep even more.
Exactly. So the clinical staff naturally gets desensitized. You hear the beep, and your brain just filters it out as background noise.
It's the boy who cried wolf.
It is. And the synthesis of all this, the real deep dive takeaway, is that when you combine poor lead placement
With an over-anxious computer algorithm.
and then add a clinician suffering from alarm fatigue, that is the perfect storm.
That's when diagnoses get missed. That's when a patient gets treated for AFib they don't actually have, or sent home with a normal ECG when they are actively having an infarct.
Precisely. The technology is amazing, but the human factor is always the weak link.
So what is the actionable advice here for the listener? How do they avoid the perfect storm?
It comes down to ownership. Don't outsource your brain to the machine.
Treat the patient, not the monitor.
Right. Take that extra 10 seconds to actually check your leads. Make sure V1 isn't halfway up the neck. Make sure V5 isn't drifting into the armpit.
Measure the regularity yourself.
Use the paper trick. It takes 5 seconds, and it's honestly better than the computer.
And verify the computer's opinion.
Treat the computer like that tired medical student we mentioned. They might be right, but you should probably double-check their work before you sign off on it.
I love that framing. It really empowers you to take control of the diagnostic tool.
Yeah.
It transforms the ECG from a magic black box into a tool you actually wield.
Exactly. It's yours to interpret.
Before we wrap up, I want to remind everyone to check out our sponsor, Whole Life Healthcare.
Right.
They're great partners in this journey of learning. And hey, if you are enjoying this deep dive, make sure you find us on Spotify, that is with a P, Spotify, and subscribe to the YouTube channel.
And smash that like button. It really does help other curious learners find these deep dives.
So as we close out, we've gone from a simple scrap of paper to complex algorithms. The ECG is this incredible 100-year-old technology, but it still heavily relies on the human touch.
It does. But I want to leave you with a thought. We talked a lot today about how the current algorithms are a bit anxious and error-prone. But the research is moving fast. There are new models, like the Queen of Hearts model mentioned in the sources, showing that AI is getting much, much better.
Better than physicians.
Potentially. In some studies, it detects occlusion MI better than human experts. So the provocative question is, as these AI models advance, will we reach a point where we trust the machine more than the physician?
That is a scary thought. If the machine says heart attack and I don't see it, do I trust the machine?
Or, because AI is a black box, we don't know exactly how it decides, will that require us to be even more vigilant about the basics? Because if you feed a super intelligent AI garbage data from a misplaced sticker...
It's still garbage in, garbage out. It might just be faster garbage.
Exactly. The smarter the machine gets, the more perfect our stickers need to be.
That is something to chew on. The tech saves us, but only if we get the basics right. Thanks for unpacking this with me today.
My pleasure. Keep measuring.
We'll catch you on the next Deep Dive.